Hello, my name is Stijn Verhulst. I'm a pediatric pulmonologist and sleep physician at the Antwerp University Hospital in Belgium. And I will give you a practical overview on non-respiratory sleep disorders in children using primarily a case-based approach. Now, for us as pediatricians, every story starts with an anamnesis, with a history. And one of the first questions, of course, that we ask ourselves as pediatricians is how can we recognize a possible sleep disorder in children? Luckily for us, it's often very easy because the parents will come to us, will come to our clinic with a clear complaint of my child, he doesn't want to sleep. As suggested here in this picture, I have a sleeping disorder. It's called children. To illustrate this, I will show you a well-known video fragment that I downloaded from YouTube, where it clearly shows that parents, they do everything for their children, especially if their child doesn't want to go to sleep. So here you see a child that doesn't want to sleep alone. And you see the father trying to comfort his child. And so far, so good. But then it starts. So every physician and every parent will know that this is not the correct action to take, because here you will sustain the problem, but it's the primary reflex of parents to try to do the first most easy step to comfort their children. But this, in the beginning, it will take a couple of minutes before the child falls asleep, but in the end, this can take an hour or more. I will skip ahead a little bit. So here, we are 10 minutes busy, the father tries to escape, child wakes up again. So this goes on and on. This can take a couple of hours before the child falls to sleep. This can take weeks, this can take months. In some cases, it can take years. And of course, the children will not have the complaint here. The children, they will sleep or they will take a nap during the daytime, but it's the parents that will come with the complaint of not having a social evening anymore and presenting to our clinic with a lack of sleep. Sometimes it's, of course, a puzzle. And sometimes we have to see if a child, yes or no, presents with a sleep disorder. Now, the situation here is somewhat different compared to the situation in adults. And just as a question to ask yourself, the daytime sleepiness or daytime tiredness is, I think, the hallmark symptoms of a symptom of a sleep disorder in adults. So I would like to ask you to answer this question, a yes or no question. Is daytime sleepiness always present in children with a sleep disorder? And the answer is clearly no. This is presented in this table from an old paper from Christian Guilleminot, who presents different symptoms of sleep disorders across different ages in children. And what is very atypical or typical for children is that the hallmark symptom of sleep loss in adults, the daytime sleepiness, is not always present in children, especially not in young children. We often see that these children will fight the sleepiness or will fight the tiredness and present with some paradoxical symptoms such as hyperactivity, irritability, concentration difficulties. So in the sleep clinic, we get a lot of children with, for instance, ADHD-like symptoms, where the question for us is, would a sleep disorder or a sleep problem, could that be responsible for the attention deficit, hyperactivity, concentration problems that these children have? So the main message for you, for the clinician, is that sleep disorders in children, can present with a variety of symptoms, and that daytime sleepiness is not always present. When you have a child with hyperactivity, irritability, or concentration problems, always do a good sleep history, because a sleep disorder could be responsible for these symptoms. Why is it important to have some knowledge of pediatric sleep disorders? Is because they are very prevalent in children. We will not go into detail of this table. This is from Medscape. You see here different prevalences of different types of sleep disorders in children, but you see here prevalences or frequencies of 20%, 30%, and so on. So sleep disorders in children are very prevalent, and especially for primary care physicians or pediatricians, it is very likely that you will see parents presenting with a normal young child who ask your advice for sleep disorders. Why are they so prevalent? That's because sleep and the sleep architecture, it knows a very rapid evolution through the very first years of life, and that's why these sleep disorders are so prevalent. So let's look at some examples of classical, typical, very frequent sleep disorders using a case-based overview. I will show you a video of two children with what we call disorders of initiating and maintaining sleep. I will show you the video. This is the first example. This is an older child. You see that this is in the sleep lab from a very long time ago. You see she needs to fall asleep with the hand touching that of the parent. And please take a close look at the hand of the child. She's pinching her hand, something's missing, and she will wake up, complain a little bit, and reach out for mom or dad who's sitting next to her to comfort her again. I will give you another more typical example. This is a younger child. He didn't need the hand of the parent, but he needed the hair of the mother to be comforted and to be able to fall asleep. Again, look at the hour here. It's past 11 at night. Also, this has been going on for several months, for several hours during the night. This is what we call a sleep onset association disorder. It's an example of a behavioral insomnia. And sleep onset association disorder means that these children cannot fall asleep if certain objects or certain persons are not present at the time of the bedtime routine. What is important in these cases of behavioral insomnia is that the majority of cases start as a disorder of initiating sleep, but it's part of the normal evolution of the sleep architecture of a child. Every child wakes up 3, 4, 5 times during the night. And of course, if a child is used to falling asleep, touching the mother or the father's hand or touching the mother or father's hair, and he wakes up in the middle of the night and mother or father is not present at the bedside, then of course he will panic and the child will ask or will cry for mother or father to come to the room just to be able to touch the hand or the hair again, and so to fall asleep. So we see that the majority of cases start as a disorder of initiating sleep, but evolve to a disorder of initiating and maintaining sleep. Our job as clinicians is to rule out any medical reasons for insomnia, like for instance snoring, sleep apnea, and so on, which is not the topic of this presentation. But if we ruled out that there's no arguments for sleep apnea, restless legs, and so on, our job is to initiate or to install a new behavior. We most often, because we are in tertiary care where the problems have persisted for several months, we do that very gradually. We make an action plan together with the parents to induce very gradual changes so that the child is able to learn to fall asleep on its own. You can use sleeping aids like a teddy bear, for instance, so that the child finds a new routine, a new aid to help him fall asleep. And what is extremely important is that parents are coached during this process. So we have sleep coaches, and sometimes we have also our psychologists who accompany patients through this trajectory, because sometimes, of course, there can be problems with other behavior during the daytime as well, where, for instance, our psychologists can offer advice. Sometimes we also use pharmacological treatment. One of the main examples is, for instance, melatonin, which will help the children to fall asleep more easy, but it's not the solution. The solution is to install a new behavior, but the melatonin can help to reach that solution more rapidly, and it can be the additional assistance next to the coaching for the parents. So you never use melatonin or other pharmacological treatment as a standalone treatment. No, it is an aid together with the action plan and together with the sleep coaching or the psychological coaching that is installed. A second case, an older child, there's no music on in the room. I will give you a second example. This child slept, he got awake, and now he's doing this. This is a very frequent phenomenon in young children under the age of 1. So, what is the diagnosis? I'll let you think that for a minute. This is what we call a rhythmic movement disorder. Head banging, body rocking are synonyms. This is usually a self-limiting entity. It's a way that the children, they learn themselves to do it, to soothe themselves and to fall asleep. In the vast majority of cases, especially in young children under the age of 1, it's a normal phenomenon. And about 60 to 70% of the children under the age of 1 have done this at least one time. Most of the time it will disappear around the age of 2 or 3, but in some cases it can persist over time. And sometimes there it can induce sleep loss if this kind of behavior takes a lot of time before the children actually fall asleep. And then you can consider treatment with, for instance, melatonin in those cases of sleep loss, to protect the amount of total sleep time that the children will have. The next case, we move to teenagers. We have a 15-year-old girl who's referred to our clinic for insomnia. She has to go to sleep around 9:30, but she only falls asleep around midnight. She has to wake up in the morning at 7 o'clock because to go to school, but she only has about 7 hours of sleep, which results in daytime fatigue and sleepiness, headache, concentration difficulties, and worse grades. Now, when you think about the teenagers with insomnia, you can pause the slide here, or you can pause the presentation here, and think about what could be relevant questions to ask to that teenager to pinpoint the reason why she cannot fall asleep in the evening. So pause the presentation so that you can think about it. Here are some of I think, the most important answers to the most relevant question. What is very important is that once she falls asleep, that she sleeps through the night. There is no waking up through the night. Very important question to ask is to ask questions about sleep hygiene. caffeine use, but also, of course, devices as the blue screens, the light exposure is, of course, very important to ask that to a teenager. The most critical question is what happens when you go to bed later. If she goes to bed in the weekend around 11 or around 12, she has no problems falling asleep. And this is a very important question to rule out psychological factors or stress factors, which she also denies of having. She has no stress, everything goes well at school, everything goes well with the friends. And also another question is, what do you do during the weekend, during the holidays, and then she sleeps in. With this kind of insomnia, it's always a good thing, especially in a teenager, to ask for possible questions of restless legs syndrome, which is somewhat of a difficult entity in pediatrics, especially in young children, because the diagnostic criteria, they require the children to describe the restless legs in their own words, which is not always a clear-cut entity, especially not in young children. I tend to have a pragmatic approach. If I suspect restless legs, I will order a blood draw to order the ferritin level, and if the values are low, I would start a pragmatic supplementation of iron. Because most of the time if it's restless legs, that will have a positive effect in these children. If you would do a sleep study in these teenagers, what we don't do, then you see that she has difficulties falling asleep, but once she falls asleep, that the rest of the night is normal. So here you have a teenager with insomnia, no effects of stress, and if she goes to sleep at a later hour, the insomnia disappears, and this is characteristic of what we call a delayed sleep phase syndrome or a circadian rhythm disorder. So here it's very important. This is extremely prevalent in adolescents, to educate the teenager about sleep hygiene, caffeine use, exposure to light, and which is not always a popular thing to say, to try to advocate the importance of a regular rhythm, especially about the dangers of sleeping in the weekends. What really works is that you use chronotherapy, which means that you let the child fall asleep at the hour that he or she falls asleep normally. So in this case, it would be 11 or midnight, and that you slowly move the hour of going to sleep a little bit earlier and earlier, with 10 to 15 minutes every couple of days. You can combine that with a low dose of melatonin in the early evening. You can combine that with phototherapy, with light therapy. But in the majority of the cases, when the teenager is motivated and you use chronotherapy with melatonin or with phototherapy, you really get good results, and you should be able to restore the teenager to a normal rhythm. But the motivation is really critical. Another case, this is, I didn't have an English version, but this is a sleep diary. This is a very easy tool to use in the clinical practice to get an idea about the quantity of sleep, about the sleep architecture and subjective sleep quality of your patients. So this is Thomas. He's 16 years old, and he comes to the clinic of his primary care physician because of daytime sleepiness and tiredness. You see here the sleep diary, the individual days here with the arrow downward. You see the moment that he goes to sleep, and when it's the gray bars or the blue bars here is when he actually sleeps. And then you see here the upward arrow, then he wakes up, and you see here a point on 10 on his subjective sleep quality. So what you immediately see that he has a very good subjective sleep quality. And here in the sleep diary, you see the most prevalent reason why teenagers are tired or sleepy during the daytime. And I hope that you can see it well on the screen, but you see that he most often goes to sleep around 1 or 2 a.m., but then of course he has to wake up at 7 in the morning. So this is a lack of sleep, which is of course the most prevalent reason why teenagers and adults are sleepy or tired during the daytime. Why is that important? Because daytime sleepiness has to be, you always have to consider narcolepsy when you see an adolescent with daytime sleepiness, because narcolepsy is a very rare sleep disorder, but it typically presents, the first symptoms typically occur during adolescence. So it's very critical that you consider a possibility of narcolepsy in the sleepy adolescent at your clinic. So daytime sleepiness is always present in narcolepsy. Sometimes you can get other typical symptoms like hypnagogic hallucinations or sleep paralysis. And then the pathognomonic feature of cataplexy, which is very, very typical of narcolepsy, but it's not always present. So for those who are not familiar with narcolepsy, cataplexy is the sudden loss of motor control on your muscles, most often triggered by positive emotions such as laughing. Sometimes you can get complete cataplexy when the patient falls to the ground because he cannot control his legs anymore, but the conscience is preserved. But you also have what we call partial cataplexy, where you, for instance, have no neck control anymore, or the facial musculature is somewhat different. So be alert also for cases with partial cataplexy. But cataplexy is very, very typical and pathognomonic of narcolepsy. Majority of cases in narcolepsy are caused by a hypocretin deficiency, which you can, in selected cases, you can measure that through a lumbar puncture. It is associated with a typical HLA phenotype, but you can also have secondary forms of narcolepsy. For instance, children with Prader-Willi, for instance, with certain genetic syndromes, can also have daytime sleepiness or a narcolepsy phenotype. It's very important to have a clinical suspicion of narcolepsy, because we know from the literature that the onset of the first symptoms until the interval between the onset of the first symptoms and the eventual diagnosis, it can take a number of years. So please be alert if you have a sleepy adolescent for the possibility of narcolepsy. If you have suspicion of narcolepsy, refer this patient to a sleep lab. We make the diagnosis through a full nocturnal polysomnography with what we call multiple sleep latency testing, the MSLTs. We ask the patient to take 3 or 4 naps during the daytime. If they fall asleep rapidly, if they have REM episodes on these naps, this is diagnostic for narcolepsy. And in selected cases, we can make the diagnosis through an HLA typing, a lumbar puncture, or a brain MRI in children with a typical presentation of narcolepsy. So this is an example of a polysomnography. You see here, it's in gray, but you see that the patient immediately enters his sleep through REM, which is abnormal, because normally you will have your first REM after at least 60 to 90 minutes of sleep. So this is something that your sleep technicians should be aware of. And you see here also, you see very, very fragmented sleep, which is also a typical pattern of narcolepsy. And here you see a typical MSLT. So these are the multiple sleep latency patterns of a patient with narcolepsy. You see 4 naps here over the daytime with a mean sleep latency of 7 minutes. So the patient slept through each nap, and in 3 of those naps, the patient also had what we call a SOREM, REM episodes, which is pathological and which is a typical feature of narcolepsy. Case 5, a 7-year-old girl. She appears to wake up around 11 most nights of the weeks, and she's very hysterical. She comes out of her bed, she screams, she's confused, but the parents, they don't have contact with her. She's difficult to comfort, and when they talk about it in the morning, she doesn't remember the episodes at all. So the parents are very worried because of this. They call it sleep attacks of history of screaming, and they request an urgent appointment to your clinic. What could be the diagnosis? And this is night terrors, and night terrors is related to sleepwalking. This is a parasomnia, a non-REM parasomnia, which is somewhat normal in young children because it happens in slow wave sleep, and toddlers, children in elementary school, they have a lot of deep sleep. So we see that these episodes of sleepwalking or night terrors can be normally occurring in these children of this age group. And normally when they reach 11, 12 to 13 years of age, in the majority of these patients, the night terrors or the sleepwalking will disappear. What is critical is that these children have sufficient sleep, because if they have sleep loss, then the nights that follow the night of sleep loss, they will recover their deep sleep. They will have more deep sleep, so that this will typically exacerbate the night terrors or the sleepwalking. There's no need to do a polysomnography in these children, especially not if they are below the age of 12. You only do a sleep study, for instance, when you have a suspicion of sleep apnea or periodic limb movements, because of course, if you have sleep apnea, this is something that could trigger sleepwalking or night terrors. You don't need to treat it because it's a parasomnia, but in this age group, it's a relatively normal phenomenon. But in some cases, this could lead to sleep loss, not in the case of the child, but in the case of the family. And then it could also induce a lot of distress in the family, and sometimes you have to use a pharmacological treatment. In our center, we have primarily we use the option of hydroxyzine, which is a sedative antihistamine treatment, which in the majority of cases has a beneficial effect on this kind of parasomnia, and is not associated with other side effects, especially not during the daytime. This was the end of the presentation, where in a number of cases I tried to give you somewhat of a case-based approach of some of the more typical sleep disorders in children. If you have questions or if you have comments on non-respiratory sleep disorders in children, you can always contact me by email. Thank you for your attention.